They drill this into you in liaison psychiatry on the medical campus. When the scans are clean, the labs are steady, and the history reads like a storm, you are treating a primary psychiatric illness. On a wet Thursday in late autumn, the EEG trend on a portable monitor gave me a reason to doubt it. I am a consultant in liaison psychiatry with a second specialty certificate in clinical neurophysiology. I have worked the interface between mind and brain for more than a decade at the University Clinical Center in Gdansk. My days are a rotation of corridors: emergency, neurology, intensive care, and the locked ward 2 floors up from radiology. The hospital's rhythms are mechanical and, on good weeks, mercifully predictable. Patients arrive in waves shaped by shift change, by weather, and by payday. The work is pattern recognition with guardrails. Rule in danger, rule out delirium, rule in or out substances, stabilize sleep, restore routines, discharge with a plan. That morning began with the usual instruments lighting up in a reliable order. The triage dashboard flagged a new admission labeled as acute psychosis. The nurse summary showed no fever, oxygen saturation within range, blood pressure pleasant for a chart, heart rate a touch fast. The basic metabolic panel was unremarkable. The urine toxicology screen displayed a long column of negatives. A non-contrast CT of the head reported no acute findings. The MRI suite was backlogged. The slot offered for this patient sat at the end of the day. The case looked like a template. A young man, mid-20s, university student brought by flatmates after 2 days of disorganized speech, sleeplessness, and bouts of agitation. No head trauma. No known psychiatric history beyond a brief counseling visit years ago. No travel. No tick bites. No new medications or supplements. According to a kitchen photo, one roommate showed the admitting nurse on a phone. The intake note mentioned odd movements of the mouth and hands, dismissed as stress fidgets. The on-call psychiatrist documented classic features: racing thought, bizarre associations, paranoid flavoring. He ordered an antipsychotic at a low dose, a sedative for the night, and placed the patient on the high observation list. By late morning, I stood at the foot of his bed on the locked unit. I do not rely on first impressions. The room, the smell, the posture of family, all of it misleads. I began with the checklist that has carried me through winters: orientation, attention, naming, repetition, commands, copying simple figures. In parallel, I scanned the nursing flow sheet for any sign of a medical trapdoor: fluctuating levels of consciousness, waxing and waning attention, myoclonus, tremors out of proportion to anxiety, autonomic swings, nighttime agitation worse than daytime. The flow sheet showed steady notes: restless but redirectable, appetite poor, sleep none, speech pressured. Then I noticed the witness that would follow me for the rest of the case: a portable EEG monitor, its small screen asleep at the bedside, brought up from neurodiagnostics to catch suspected subclinical seizures the night before. The tech had placed a limited montage because the patient would not tolerate the full cap. When I tapped the screen awake, the recorded trend bars did not match what we teach. The overall amplitude was low, almost damped for his age, yet the behavior documented by nurses had been florid. Usually, when the mind is roaring, the scalp picks up a bustling background. This looked hushed. Not flat, not absent, but quiet in a way that made my training lean forward. I ran the rest of the exam. Language was chaotic but intact at the single-word level. Attention flickered, and then held when I shifted to nonverbal tasks. He followed midline commands better than lateralized ones. His eyes tracked sound, but would fix on corners as if something there deserved respect. Then came the movement I could not place, a brief, purposeless grin, followed by puckering, then a chewing motion without food. It lasted seconds, repeated, and stopped when I spoke his name in a firm tone. Nurses had labeled these as nervous habits. To me, they read as orofacial dyskinesias, the kind of semi-automatic movements I had seen in autoimmune encephalitis and in some toxidromes. The lab screen remained unsupportive. White cells fine, liver and kidney calm, C-reactive protein unremarkable, thyroid normal, B12 and folate pending, no anemia, no electrolyte insult. On the psychiatric side, that pattern earns you the stamp of primary illness with a gentle note to review if the picture changes. On the neurological side, the movements plus insomnia plus a young male without substance use push you to think of the rare but dangerous. The standard doctrine says antibodies decide. If the serum and cerebrospinal fluid are negative for neural autoantibodies, you step back. You do not chase zebras while the horses are running. By early afternoon, I asked the charge nurse to page neurodiagnostics. I wanted a supervised bedside EEG with a fuller montage and a trigger log to correlate behavior with waveforms. The tech arrived with gauze, paste, and patience. The patient tolerated more electrodes than expected. We recorded eyes open, eyes closed, hyperventilation, photic stimulation. The trend bars settled into the same quiet pattern with occasional bursts that did not line up cleanly with the lip and hand movements. When the mouth began its sequence, the cortex did not answer in any stereotyped way. The tech shrugged in the polite way of experts who have seen everything and are loyal to their data. She saved the file and promised a formal read. The MRI call came as the sky turned the color of dirty snow. Transport wheeled him to radiology. On the way, his pulse spiked and settled. Autonomic lability is not proof of anything in psychiatry, yet in this context, it shaded the picture. The MRI returned blank. No inflammation, no mass, no diffusion restriction, no signal changes to anchor a story. The neurologist on duty wrote a measured note. No focal signs, no meningeal signs, no seizure phenotype on exam. Recommendation: continue antipsychotic, consider dose adjustment, consider sleep protocol, reassess in the morning. At evening handover, the monitor became insistent. The portable EEG spat out a run of raw traces that the bedside software labeled as artifacts. I watched the raw feed for a minute, then two. The movements came again. A grimace, a chew, a right-hand fidget, all brief and without obvious trigger. The waveforms stayed mostly small, with rare sharp transients that refused to settle into any rhythm a machine could name. The nurses marked the events in the chart. The tech's report posted later. Background slowing for age, low amplitude, no definite epileptiform discharges, captured behaviors without EEG correlate, recommend clinical correlation. That last phrase is medicine's shrug, the rule held on paper. Clean head imaging, clean basic labs, tox negative, psychiatric presentation, a hint of soft neurologic signs, yes, but not enough to change course. I should have signed the note and moved on. Instead, I opened a long consult template I save for the cases that itch. I documented the orofacial movements in detail, the near insomnia despite sedation, the swings in heart rate and pressure at odd hours, the unhelpful but interesting EEG quiet, and the way his attention improved on nonverbal tasks that bypassed language. I wrote the words that move a case out of the lane and into debate. Consider autoimmune encephalitis, request cerebrospinal fluid studies, and send extended neuronal antibody panels on serum and CSF. I added a line that would haunt me. Do not escalate antipsychotic dose until organic causes excluded. The pushback was immediate and polite. Beds were tight. The lumbar puncture bay was overbooked. The extended panel would take weeks, and the first pass serum tests were often enough to rule out the rare. We had no fever, no stiffness, no classic movement disorder beyond subtle mouth and hand patterns. The patient's family, when reached, described a month of stress and late nights before the break. They asked if we could please help him sleep and quiet his thoughts. I carried the portable monitor's quiet trend in my head, like a wrong-sized cog. When the mind is roaring, why does the cortex whisper? When behavior explodes, why does the electrical surface barely stir? You can lose scalp signal when the storm lives in deeper circuits, or when inflammation changes how synchronized neurons are, or when medications dampen the signal. All of those are possible, or the answer is simpler. The monitor is temperamental. The montage is limited. The movements are not neurological at all. As night shift settled, I stood one more time in the doorway and watched the pattern repeat. Restlessness, a flurry of purposeless mouth and hand motion, a brief stare at the corner, then a sag back into the sheets. The nurse adjusted the blanket. The monitor prickled with small spikes and then calmed. The note on my screen showed my request in the task list, like a stone on a path. The doctrine was clear, and the pathway was paved. But the monitor's quiet did not match the room's noise. The next morning started with a meeting that moved like a conveyor belt. Bed status, staffing, scans, discharges. When the patient's initials came up, the plan stayed inside the lines. Increase the antipsychotic by a small step. Repeat labs at midday. Continue observation. Hold the lumbar puncture until neurology could spare a slot and sedation. I marked the time and wrote a second request for cerebrospinal fluid. I attached the EEG summary with the same quiet background and the same mismatch between behavior and surface signal. At mid-morning, the first evidence beat arrived, small but stubborn. The overnight vitals showed seesaw changes without a tidy trigger. Heart rate wandered up and down. Blood pressure did the same. Temperature stayed normal. The nurses had recorded that he barely slept despite medication. On the video review from the corridor camera, the orofacial movements appeared in brief bursts, then vanished. These were not grand seizures. They were something subtler. The portable EEG, our witness, recorded the same low-amplitude hum. It was as if the orchestra pit had emptied while the stage played to a full house. By noon, the second beat clicked in. Serum tests for common neuronal antibodies returned negative. That result gives everyone relief because it supports the rule: if the blood is clean, the mind is probably primary. The neurologist added a line to the chart that read like a period at the end of a sentence. I asked again for cerebrospinal fluid. In this hospital, that request is a cart that needs many hands. Consent, sedation plan, ultrasound availability, post-procedure bed. The response was practical. The day list was full. If the picture worsened, we would move sooner. If not, tomorrow. The afternoon was a grind of little tasks. I sat with the family and took a longer history by phone, building a timeline that could justify the spinal tap. Over the past month, the patient had stretched his days late and his nights thin. There had been a sore throat a week before the collapse. There were brief spells of staring, written off as distraction. There was a new clumsiness when typing. None of it met the threshold for alarm until speech unraveled and fear took over the room. The housemates had done their best. They had no anchor for what they were seeing. Near evening, the third beat landed from neurodiagnostics. A formal read of the extended bedside EEG background rhythm slower than expected for age. No definite epileptiform discharges. Captured behaviors without electrical correlate. Recommendation: correlate clinically. That phrase again. A shrug dressed as a sentence. I carried the report to the ward round and made the case one more time. The pattern of movements, the near-total insomnia, the autonomic drift, the odd way language failed but nonverbal tasks sometimes broke through. The quiet scalp signal that should have been louder if this were simple mania. I asked for a trial of immunotherapy to hedge the risk while we waited for fluid. The answer was simple and not unkind. Not without evidence. Before midnight, a slot opened in the lumbar puncture bay. The nurse called me because I had signed the request. We brought him down with a small dose of sedative. Positioning took time. The resident found the space. The opening pressure was within range. The cerebrospinal fluid came out clear. We sent tubes for cell count, protein, glucose, oligoclonal bands, infectious panels, and an extended neuronal antibody panel. The lab clocks stamped the samples as they passed into the system. I watched the accession times post into the record like coordinates on a map. Back on the unit, something shifted. The antipsychotic increase made him calmer, but also slowed his face. The small mouth movements grew more obvious when the rest quieted. He still did not sleep. Near dawn, he stood and stood again, as if his joints had forgotten what bed was for. The nurse set the safety belt. The monitor caught the same hushed electrical landscape. The room was noisy. The cortex kept its whisper. We pushed sleep protocol harder that night. It did not stick. The next day, the first cerebrospinal fluid numbers arrived. Mild lymphocytic pleocytosis, protein slightly higher than before, glucose in normal relation to serum, oligoclonal bands pending, infectious markers pending. This was the fourth beat, and it did not salute the rule. In primary psychiatric illness, spinal fluid is a lake without ripples. This lake had small waves. The neurologist adjusted the note. The infectious disease consultant added a list of tests to exclude the usual culprits. The antimicrobial team argued gently for watchful waiting without broad coverage. The family asked again, in careful language, if we were sure we were not dealing with stress. By late afternoon, a formal meeting gathered in a small room with a window that stared at a brick wall. Stakes had to be named. The institutional risk was simple. If we treated for an autoimmune process without proof, we would expose a young patient to drugs with serious side effects. If we did not treat, and this was one of the rare but real antibodies that only declare themselves in fluid, we would lose precious time. The human risk was heavier than either. The patient's trajectory felt worse at the edges. My personal stake was smaller on paper and larger in the head. I had planted my flag on a narrow hill. If wrong, the label would be zeal or worse, fixation. If right, the label would still be trouble, because I was asking colleagues to step off the paved road. We decided, as a group, to split the path. Antipsychotic dose would pause. Sleep would be pursued with non-antipsychotic measures. We would watch the fluid. If oligoclonal bands or a higher cell count appeared, we would consider a trial of steroids while the antibody panel crawled through the pipeline. I walked out with a feeling like rain pressing on a window. The next 24 hours ran on repeats. The movements came and went. The portable EEG wore its quiet like a mask. A repeat MRI with contrast remained clean. The corridor camera showed longer spells of pacing. The nurse wrote that he ate little. The autonomic seesaw kept up. I checked the lab portal too often. No one admits that habit, but we all do it. Then came the mid-act rupture. In the morning, the serum neuronal antibody panel was reported again, this time as a full extended set, all negative. At noon, the cerebrospinal fluid cell count ticked up by a small step, and oligoclonal bands posted as positive. The same patient, the same day. The blood said no. The fluid said maybe. The rule says serum is the convenient anchor. But a clean serum in a young adult did not match inflammatory fingerprints swimming in cerebrospinal fluid. I wrote the second contradiction line in my note because the chart should witness what the room is seeing. The patient looked more neurologic while the most comfortable test stayed negative. We moved to steroids by late afternoon, a modest course with a plan to stop if nothing changed. The pharmacy released the vials. The nurse hung the first dose while the portable monitor kept its hush. Here, the case stopped being only about a patient. It became a mirror. A senior colleague pulled me aside and suggested a break. My notes were long. My presence on the unit was constant. I was not sleeping well. I knew that because the badge logs showed me tapping in at odd hours, and the coffee cups on my desk confirmed it. I declined the break. The next night, I lay down on the sofa in the call room and never fell asleep. When morning came, I felt like the hospital sounded, fluorescent and thin. The department head suggested I check myself out of the building for a day or two. I did not. I rounded again and wrote again. The charge nurse, who had seen many versions of me across many winters, placed a quiet call to the staff doctor who covers staff. That afternoon, I agreed to be evaluated in the same building where I round. The irony was plain and was not funny. The exam was gentle and procedural. It ended with a short hold for rest and observation. I walked across a threshold I usually cross in the other direction. From inside, the sounds are different. Doors carry their own weight. Clocks shift from patient time to staff time to something else that sits between. I asked for one thing while I was on that side: access to the chart for the patient whose case had put me there. The answer, correctly, was no. Over the next 2 days, I learned small lessons about pacing, about how even senior staff need rails when sleep and certainty vanish. The portable EEG could not follow me, but its quiet screen followed me in my head. While I was away, the steroid course finished. The family consented to a trial of intravenous immunoglobulin after a tense morning wake-up that looked like a brief spell of confusion. The infectious panels stayed negative. The cerebrospinal fluid antibody panel, the one that takes too long, sat somewhere in a lab 2 cities away. I returned to work with a cleared note and a smaller voice. The patient had changed, not cured, different. He had slept for the first time in days. The mouth movements were fewer. The pacing spells shortened. The portable EEG still showed a low amplitude background, but the rare sharp transients had gone quiet. The nurse wrote a line that mattered more than any study. He engaged with morning care. We all wanted to declare victory. The rule likes closure, but the numbers still read like a question. Serum clean, fluid noisy, imaging blank. Behavior better after immune therapy. That by doctrine, we should not have started without proof. We agreed to taper and watch. A week from the first day, the envelope finally arrived in the electronic record with a simple lab header and a long list of targets. One line carried a mark. The cerebrospinal fluid showed binding to a neuronal surface antigen, consistent with an autoimmune encephalitis, known for psychiatric first presentations and stubborn insomnia. The serum remained negative. The rule had failed where it was most comfortable. The witness had told us quietly all along that the stage noise did not match the pit. The diagnosis did not solve everything. It did not erase the days he had lost, or the days I had lost. It did, however, pull us back onto a path we could walk without arguing. We set a full immunotherapy plan. We wrote a care map for sleep, for rehabilitation, for family teaching. And I faced the other ledger, the one with my name on it, and the chart that showed where I had crossed my own limits. I filed an incident report on myself for boundary failure by presence rather than by action. I met with the department head and with occupational health. I wrote a short note for the board that named the stakes as they had been. Personal credibility bent, institutional policy stretched, human outcome held only because a witness device had kept whispering the same line. The report ended with a sentence I did not enjoy writing. What I believed had been right, and how I carried that belief had sent me across a door as a patient. The case moved to follow-up. The patient began to string sleep into nights. Speech settled into clean lines. The mouth movements faded into the kind of noise the lab result that broke the stalemate posted on a Wednesday in late November, just after midday. The cerebrospinal fluid panel showed binding to a neuronal surface antigen known to present with relentless insomnia, behavioral change, and subtle movements that confuse the exam. The serum panel stayed clean. The rule that blood leads and fluid follows did not hold. The witness at the bedside had been telling us that for days, not with spikes, but with a hush that did not fit the noise in the room. We changed course in steps small enough to be safe and large enough to matter. A second cycle of immune therapy was written, this time without debate. The antipsychotic was tapered off. Sleep protocol remained, but now as support rather than primary treatment. Physiotherapy came to the bedside to keep pacing from becoming deconditioning. The family met the team and received a plan in plain language. Treat the inflammation, protect sleep, watch thinking and movement. Expect a slow climb rather than a leap. The first marker of improvement was not a number. It was a night where the nurse charted continuous sleep longer than any since admission. The corridor camera recorded fewer pacing loops. The mouth movements quieted to background noise. On morning review, he copied simple figures without losing the line. The portable EEG remained a soft landscape, but no longer threw stray, sharp transients at odd hours. The pit was still muted, yet the stage had calmed to match it. On the Friday of that same week, occupational therapy added structured daytime tasks. In the afternoon, he ate a full meal without prompting. Vital signs, once a restless tide, flattened into a small drift that pleased the cardiology monitor. We stopped measuring progress in grand claims and started tallying basic wins: sleep, meals, attention, short walks, a shower taken without staff standing close. The chart carried a second current, my own. Occupational health cleared me back to full duty with a condition written in ordinary words. Keep regular hours. Hand off when past the end of the shift. Accept second opinions early, and step away when the work follows me into the night. I signed without protest. The staff doctor who had evaluated me wrote a short note that fit the case better than any label. It said that zeal under sleep loss had narrowed my vision. It did not call me unfit. It called me human. Institutional change began as a hallway conversation and ended as a policy line. On the first Monday of December, our department adopted a small rule with a wide shadow. When a patient under 30 presents with first episode psychosis, with near total insomnia, odd movements, and a negative toxicology, The default is to send cerebrospinal fluid for neuronal antibodies even if serum is negative, and to consider a short, carefully monitored trial of immune therapy if cerebrospinal fluid shows inflammatory signs before the antibody result returns. The rule included a counterweight. A second consultant, preferably from neurology or immunology, must co-sign. The goal was clear. We would not let a single voice bend the system. We would also not let the system ignore a quiet witness. Human fallout remained the hardest ledger. The patient stabilized enough to leave the locked ward in the second week of December. He moved to a neurology step-down bed with a plan for daytime therapy and nighttime sleep protection. He did not return to his studies that term. He learned to pace his days. The family learned how to notice small slips without panic. Before the holiday break, we fitted him with a light, portable monitor to use at home for short intervals, more for reassurance than data. He walked out with a discharge summary that named his illness in plain words and avoided grand promises. The staff who had watched him circle the ward clapped once in the doorway and then went back to work. For me, the cost was quieter. Colleagues who had trusted me before now watched my notes with a little more scrutiny. It felt fair. I attended fewer meetings and spent more time reading case series and auditing charts where insomnia and movement had been written off as stress. I found a handful that deserved a second look. Some were stress, a few were not. We brought those patients back for fluid tests. One returned a positive result and began therapy that same week. Most did not. The point was not to be right often. The point was not to miss the few when the price of missing was high. In January, at the first Morbidity and Mortality Conference of the year, we presented the case. The slide deck was sparse. No special fonts, no grand arcs. The witness object led screen captures of the low-amplitude background during obvious behavioral activation, side by side with notes that showed nurses struggling to anchor what they were seeing. Imaging slides were blank by design. The lab table showed the contradiction in gentle print. Serum negative, fluid positive, oligoclonal bands present, mild pleocytosis. A simple graph mapped the change after steroids and immunoglobulin. More sleep, less pacing, cleaner attention tasks. The last slide was a policy card with the new rule in 5 short lines. The questions were dry and useful. How many false positives will this generate? How do we audit appetite for immune therapy against the harms? What guardrails keep zeal from becoming a default? Each was answered with the practice change already written. Co-signature, clear thresholds for trials, rapid stop if no benefit, and a small audit of all such cases every quarter. No one used the word miracle. No one used the word mystery. The room settled on a phrase I can live with: plausible but uncomfortable physiology. The patient's course over the next months was steady with small dips. In late January, he had a brief setback after a viral illness. We treated promptly and avoided a relapse. In February, the portable monitor was retired. In March, he attended a half-day clinic to rebuild study habits. In April, he sat in the waiting room with a book and did not pace once. By early summer, he returned to part-time study with accommodations. He came back to clinic with a list of questions about sleep hygiene and flare warnings. His chart now reads like an ordinary life with added instructions. The institution's course was slower. In spring, the audit of first episode cases showed an increase in cerebrospinal fluid testing. Not dramatic, but measurable. The rate of positive antibody findings did not climb in step, which was expected. We adjusted by tightening our trigger list. Severe insomnia, subtle movement disorder, autonomic drift, and either a quiet or paradoxical surface, EEG. The list stayed short on purpose. A checklist can help. A long checklist can hide. By mid-year, the badge logs showed a difference I could feel. I was leaving the building near to the end of shift and not returning at odd hours. The portable EEG screens I passed in corridor bays did not follow me out. The staff doctor closed my monitoring file with a sentence I copied to a sticky note. Protect the work by protecting the worker. There is a temptation, after a case like this, to fix it with a story. I resist that. The numbers never became clear enough to bear the weight of a legend. Serum stayed silent. Fluid spoke once in a lab 2 cities away. The witness at the bedside did not prove a diagnosis. It only told us the show on the floor did not match the sound from the pit. Immune therapy helped, then helped again. That is not proof. It is a direction. There is also a temptation to grow suspicious of every clean scan and every negative blood test that sits beside a roaring mind. That is a road to chaos. Most first-episode psychosis is not autoimmune. Most insomnia is not a harbinger. Most odd movements are stress and side effect. The point of a rare case is not to make every case rare. The point is to keep a small door open when the ordinary road refuses what the room is showing. I keep one unresolved question on a card in my desk. It is not mystical. It is practical and dull. The question is whether we can teach the staff who first touch these patients to spot the pattern without needing a specialist at the bedside. The pattern is this: a young patient who simply cannot sleep, whose face moves in small, purposeless ways, whose pulse and pressure drift without fever, whose surface EEG stays too quiet for the room, and whose serum is clean. Nothing in that list is loud. Together, they are a flag. We are building a short module for triage nurses and first-year doctors to practice it. If it works, fewer patients will need an advocate with a second certificate to keep the door open. On a mild afternoon in late summer, the patient returned for a routine review. He arrived on time. He answered questions at a normal pace. He described nights with sleep and days with classes. He did not remember the early days clearly and did not need to. I had nothing to add that would help him, so I signed the note and walked him to the lift. On the way back, I passed a trolley with a portable EEG. The screen was dark. I tapped it by habit. It woke and showed a flat menu waiting for a case. I let it sleep again. I have not removed the case file from my desk. It sits under a paperweight beside the incident report I filed on myself. They serve different purposes. One keeps me honest about the patient. The other keeps me honest about me. I do not need grand meanings. I need rails I can reach when the room is noisy and the pit is quiet. The final act of the case did not end with a discharge or an award. It ended with a procedure code added to an order set, a co-signature box added to a form, an audit calendar entry, and a reminder on my phone to leave the building by dusk, unless the building truly needs me. It ended with a patient who went home and stayed there. It ended with a witness object that returned to its cart with nothing to say, which is how it prefers to live. I walked out one evening in early autumn with my coat on my arm and the badge in my pocket. The sky was the color it often is in this city, a soft gray that does not pretend. The hospital hummed in its usual way. Somewhere on a ward, a monitor beeped. It did not call my name. I went home.